Okay, today's discussion is going to be on cardiac dysrhythmias, and we can look at cardiac dysrhythmias by using an electrocardiogram, a graph of our electrical activity in the heart. We run a paper through at a defined speed and we measure the electrical activity. So we're talking about cardiac dysrhythmias. And in the diagram that we're looking at right now, we're looking at what's called a normal sinus rhythm. So remember that our pacemaker was called a sinoatrial node. So that's where this sinus rhythm terminology comes from. And we identify the electrical activity in the heart as atrial contraction followed by ventricular contraction. This raised area here is called the P wave, and followed by the QRS complex, which is ventricular contraction, and then repolarization of the ventricle is the T wave. Then we have a space, and we repeat atrial polarization of the atrium can't be seen on an ECG because it's buried by the electrical activity from ventricular depolarization, the QRS. Buries that wave. It's there, but it can't be identified because coming from the ventricle. So the other thing we can see when we look at this is that the pattern is regular. The spacing between the ventricular contractions is predictable, and more or less it's equal. So that's giving us sinus rhythm. Atrial contraction before ventricular contraction, and the spacing between the two. If we looked at ventricular contractions, 1, 2, 3, 4, and a little bit, and so on. Equal distribution between the peaks. So a normal sinus rhythm. So what happens if we end up with dysrhythmia? What we're concerned about is abnormal cardiac conduction. And our most pressing concern, the concern that we're worried about most, is if our sequencing, if our conduction patterns become so dysrhythmic that we are no longer able to generate strong ventricular contractions. It's either out of order or there's reduced filling time, that sort of thing that basically prevents the ventricle from giving an adequate cardiac output. Remember when we talk about heart failure is the inability of cardiac output to meet demand. So if the heart is weak, it may not meet demand. If its sequencing is out of order, it may not be able to fill adequately and therefore fail to deliver on cardiac output for that particular reason. So there's three main categories. So our big concern is the effect on cardiac output. That's just what we were saying there. So three categories of dysrhythmias. There's abnormal rates generated from the sinus rhythm. So abnormal sinus rhythm. We can have abnormal sites of impulse initiation. So in other words, on the next slide, I'll show you. So abnormal sites of impulse. So we go from the SO node to the AV node, from the AV node to the AV bundle. If we skip any of those pathways, that's what we're talking about. We're going to initiate an impulse from another location. It's going to interfere with this sequence. And then our third abnormality is when we get abnormal conduction pathways. Those are a good example of those are called blocks, conduction blocks. So we block the normal pathway completely, and we're either going to have to figure out another way to get around it, or obviously our sequencing is going to be severely altered based on those blocks. So we're saying abnormal conduction pathways as our third category of ECG abnormalities. So here is what we're looking at when we talk about our pathway. So our conduction pathway starts, I better get a color that we can all see. Let's get a color that's going to show up at our SA node. Here's our SA node right here. And the black lines are showing electrical activity generated from the SA node passing through the atrial wall. And that shows up on our ECG over here. The dark green lines are showing a conduction pathway with no excitation. In other words, we're going to send signals to the next node, the AV node, without excitation. The black lines represent excitation, so that means our atria will contract first. And then we're going to signal the AV node to start the transfer from the atrial muscle wall to the ventricular one. But there's resistance in the AV node, so there's a delay. And the delay is going to continue because we're going to leave the AV node through the AV bundle, the bundle branches, and the bundle branches are going to finish on Purkinje fibers. And I'm going to put them in black. Our Purkinje fibers are going to be signaled by these conducting fibers, or these so-called non-conducting fibers. Sometimes they're the terminology refers to, but at either rate, the green does not generate excitation. The excitation will start with the Purkinje fibers in the apex of the heart. In other words, at the bottom. And we're going to generate excitation in the ventricles from the bottom and head back up. And what do we find when we head back up? The aortic valve on the left ventricle and the pulmonary valve in the right ventricle. So we're squeezing the bottom of the toothpaste and pushing it towards the exit, pushing it towards these valves. So it's a sequence that's very efficient. It's not the whole wall contracting at one time. There's a sequence. That's what we referred to in the lecture after test 2 as a functional syncytium. The myocytes are connected to one another in such a way that they can work as a syncytium. And this second group of black lines would be represented by our QRS complex, which comes after the P wave. Atrial contraction first, ventricular contraction second. So what happens if this goes wrong? So remember, we said we've got a couple of things that we want to keep in the back of our minds whenever we're starting to look at these different patterns in the ECG. So we want to be aware. So for an abnormal ECG, we want to always, when we look at these ECGs, the first thing we want to consider is what is the underlying pathology? In other words, what's causing this abnormal ECG, this abnormal electrical activity? And then the second thing is, as we mentioned on the previous slide, what's the effect on cardiac output? Is cardiac output affected? So that's ultimately the only thing we're concerned about when we think about the function of the heart. As long as cardiac output's being met, we can sort of deal with pretty much everything else. So we want a couple of things we want to remember is we want to remember what the sequence is supposed to look like. And then when we start to look at some of these abnormal ECGs, those abnormal ECGs might represent. So the first one we're going to take a look at is a rate difference. So we're going to take a look at this drawing right here, this ECG, and we can see in this EG, if you remember, I said between the QRS complexes, there were 4 squares, just a little over 4 squares. Now we can see here that there's not much more than 2 squares between. So this would represent a tachycardia. This is it's a sinus rhythm abnormality. In this case, it's an increased heart rate. Now, within reason, as we've talked about multiple times with systems, especially the cardiovascular system, and later concept with the respiratory, and this looks like it's been cut in half. So this might represent 120 beats per minute, for example. So in tachycardia, we've got an increase over the resting heart rate. It may be explained by or exercise or those sorts of things. But the point we've got here is we're still maintaining our order of sequence. We've got a P wave, we've got a QRS complex, P wave, QRS complex, and the T wave is being represented in this drawing as well. Now you can see here, actually, the way I've drawn, the way this particular tachycardia goes. Let me show you something. When I look a little closely, here's our QRS. They're happening on a regular basis. So this is just a sinus issue. We don't have an interruption in the cardiac output, very likely here, unless it gets extremely fast. And then we change the terminology because our ECG is still showing that there's atrial contraction prior to ventricular contraction. So there's our P wave. It's kind of blended with the end of the T wave. That's T, that's P, and this is our QRS. So the sequence is still there. The frequency has been increased, and this is just an example then of tachycardia. The opposite to tachycardia is, so in bradycardia, it's a slower heart rate. But again, we can see that the sequencing is good. What we have is a longer interval between beats. This would represent a longer filling time. So the first 2 ECGs that we've looked at do not necessarily represent any kind of pathology. If there's a clinical picture that reflects the possibility and then we add the ECG to the equation, maybe it does. But this may just be a very fit individual who has a resting heart rate closer to 40 or 50 rather than between 60 and 90. And we can see that our P wave is represented, our QRS is represented, and our T wave is well represented. Sequence is there, cardiac output is likely going to be completely adequate in these examples. So these are just sinus rhythm differences. This is very slow. The previous one we looked at was very fast. Fast and slow. Now, we can get sinus rhythm disorders that start to become, at least potentially, pathological. In other words, they may interfere with cardiac output. So we can have atrial abnormalities. So pathologies associated with the atrium that would be categorized as what are called premature atrial complexes. So in premature atrial complexes, the P wave is going to look odd. There's going to be something different associated with the P wave and its relationship to the ventricle. So basically, these are electrical problems that begin in the atrium, but not at the node. So this wouldn't be a sinoatrial rhythm issue. It's a situation where there's been pathology associated with the atrium itself. So contraction is going to occur earlier than normal, and the P wave is described then as premature. So it's not usually clinically significant. I think I've got a picture. I'm going to show you that in just a minute. Actually, not so much this one because it doesn't have a lot of clinical. It may be experienced by the patient. They may feel a little flutter in their chest, but it doesn't interfere with cardiac output most of the time. So it's usually an incidental finding on an ECG. But one of the other ones that starts to take on a little more significance is called atrial flutter. And in atrial flutter, there's a couple of variants. In type 1, the flutter rate may go up as high as 240 to 200 or to 350 beats per minute. And it shows up as a bit of a sawtooth pattern. I'm going to show you that in a second. Type 2 is when the flutter occurs at a greater rate than 350 beats per minute. So this one's going to look like a sawtooth. I'm going to show you. And basically we know that there's some underlying cardiac pathology. There may be fluid overload. In other words, the tissue, the cardiac pericardium has got some fluid filled over it, or there's some atrial ischemia. So our sawtooth is going to look a little bit like this. So here we're looking at what's described as a sawtooth pattern. You can see here that we've got multiple atrial contractions between the ventricular contractions. So the atrial activity is overriding any repolarization. In this sample here, we've got 1, 2, 3, 4 P waves before one QRS complex. Now, the QRS complex remains relatively equal, so cardiac output is probably not unduly affected in this example. Now, if we go to the extreme, and that's basically when we have the atria reproducing contractions even faster than flutter, it's called fibrillation, atrial fibrillation. And atrial fibrillation looks like this. So it starts to look a little messier. You can see in our example here that we've got multiple, well, I better get a color that you can see, multiple atrial contractions, all blended in between ventricular contractions. So we're still getting filling, but we're getting a lot of fluttery, a lot of weak contractions trying to fill the ventricle. And you can see that the spacing between the ventricle contractions is becoming a little irregular. So it is beginning to affect cardiac output. We've got some shorter and longer intervals between contractions. So in fibrillation, there's much more disorganization. And it affects both the atrial contraction and the ventricular contractions. Our atrial impulses, they look squiggly. That's a nice simple way to describe it. They're smaller, they're squiggly. A lot of them are blocked at the atrioventricular node. So that means there's no signal being delivered to the ventricle. And then if we don't get a signal being delivered to the ventricle, then we're not going to get ventricular contraction. So we see some delays in ventricular contraction, those longer intervals. And when we get delays like that, blood can become stagnant. And if it becomes stagnant, it may be a little prone to thrombosis. So if what we call atrial fibrillation is chronic, then part of the treatment plan may be antithrombotic medications to make sure that that is not going to happen. Because, of course, if thrombosis happens, then there's an increased risk for cardiovascular ischemia, a heart attack. So sometimes the treatment for this type of a problem is what's called cardioversion. And cardioversion is an electrical stimulus to the heart wall to try to reestablish the normal sinus rhythm, to interrupt this fibrillation that's going on. Not effective, then calcium blockers and beta blockers may be part of the treatment plan to try to slow down the frequency of contractions and reestablish some regular patterning in the sequence of contractions. Now, defibrillation, you've heard that term before. Let me get back to a slide we can read from. So let's just get this one down as well. So we had atrial flutter, then we had atrial fibrillation. And the main thing that we saw was that we had very, very fast and uncoordinated atrial contractions. Square bracket means a contraction in my little summary there. And it creates effects to both the atria and the ventricle. The atria are unable to conduct effectively through the AV node, and the ventricles are sometimes not filling in a sequential manner. So there is going to be an effect on cardiac output, a negative effect on cardiac output. And the atrial complexes, which is just another way of saying the atrial contractions, are small, and we said squiggly in appearance. So our concern is stagnant blood flow leading to thrombosis. So our treatment may have to include antithrombotics, particularly if this is a chronic condition. But we also may include cardioversion. So cardioversion is not the same thing as defibrillation. And with cardioversion, it's targeted. It's targeted, in this case, to the atrial tissue to try to reestablish a pattern. We may also have to consider calcium blockers. We know that the calcium was responsible for the sustained contraction in a cardiac muscle cell. So calcium blockers would try to interfere with that sustained contraction. Or the beta blockers, the blockers that were designed to prevent epinephrine stimulating contraction and increased rate of contractions. So the blockers would slow all of that down, reduce the demand on the cardiac muscle cells. So I mentioned cardioversion is a type of what's called a synchronized to a specific time in the cardiac cycle to try to reestablish the proper sequence of electrical activities, try to restore the electrical conduction of the heart. Whereas defibrillation, I don't want to put it in under treatment here. So you know about these defibrillators that are found in hockey rinks now, and you would have them in hospitals, of course, and places but in some public places now they're starting to post them. So this is the idea behind defibrillation is it's a therapeutic dose of electrical activity, but it's random in its application. So you can apply it at any time in a cardiac cycle. And again, it's designed to, it usually increases the electrical energy that's being used. So it's not sequence dependent. That's why minimal training can be used to help the public administer a defibrillator on a patient or on a member of the public that's out, has been playing pickup hockey and has fallen over because of some sort of myocardial event. So it isn't about sequencing to the existing cardiac cycle. So this one is random, as opposed to synchronized and targeted, we'll call it. So those are a couple of examples of some atrial changes. And we've got some samples that we showed you what they look like. Now, if we go to here, and I want to just put in a new layer. So let's get out of here and look at some ventricular changes. So we have some of the similar sort of terminology. We've got what are called premature ventricular complexes. So they're abbreviated as PVCs, premature ventricular. So these are going to show up as unusual QRS complexes. So this is a problem now with the ventricular myocardium. So normally the sinus discharge, the sinus pattern to the AV node is normal, but the contraction in the ventricle is abnormal. So we have normal sinus signals, but abnormal ventricular contractions. So if we have an abnormal ventricular contraction, we're going to get an abnormal QRS. They might be repolarizing rather than depolarizing. It's going to be noticeable if someone has a history of coronary artery disease, abnormal electrolyte concentrations, especially if it's hypokalemia, low potassium levels, or magnesium. Those will show up with abnormal ventricular rhythms. And the cardiac output, of course, is going to be compromised as soon as the ventricular contraction is compromised. Now, occasionally these PVCs will be asymptomatic, but if they're symptomatic, affecting cardiac output, they need to be treated with medications that are designed to try to correct the dysrhythmia. I'll show you some pictures in 1 second. Ventricular fibrillation, just like atrial fibrillation, except that the pathology is now in the ventricle wall instead of the atrial wall. We're going to have very fast, uncoordinated ventricle contractions, sometimes described as quivering. Remember, this is going to be the bigger part of the heart, and it's going to have a direct effect on cardiac output. There's a lack of effective contractions, so it's a little bit like, when I say that the Purkinje fibers squeeze from down up, back in a nice sequential pattern back to the aortic valve or the pulmonary valve in the ventricles. In this case, it's like squeezing the toothpaste from the middle. It becomes very less efficient, and we're getting desequencing. And so the contractions are happening, but they're not effective. You're going to squeeze from the middle, for example, and push some blood down and some blood up. It's less efficient. And in the visual on this, there'll be typically no identifiable QRS complexes. Because to see a nice, clean QRS complex, we have to have that sequential contraction. So it can sometimes progress from a ventricular tachycardia into a fibrillation. In tachycardia, our rhythm was regular, but in our fibrillation, it's going to become irregular. And the treatment for trying to prevent that progression is CPR and defibrillation. The earlier the better as far as that goes. So what is this going to look like? We're going to look at premature ventricular complexes right here. Why didn't that show up? Slide 9 should show up. That's the one we've already talked about. Okay, so in this picture, what we're looking at the top is we're looking at what are called premature ventricular complexes. Remember, we said with premature ventricular complexes, we're getting a normal sinus signal. So our pace is okay. That's what in our picture here, we would have our P wave. Why is that not writing? Okay, I think we have things figured out now. So here we are looking at a normal P wave with a QRS complex that works in this case, but we're not going to get a normal QRS in every situation. So look what's happening in the next sequence. And then a long delay, a normal QRS, and then some sort of a variation on that QRS. These are described as premature ventricular complexes. They're very irregular. And in this view here, what we're looking at is ventricular tachycardia. Remember, we said with ventricular tachycardia, we're going to get the electrical activity of the ventricle dominates over any other pattern. And the concern with tachycardia is the effect on cardiac output and that it may progress to a fibrillation, a ventricular fibrillation. And in ventricular fibrillation, we see this varied irregular patterning, fast, uncoordinated quivering of the ventricle, no identifiable QRS complexes, and we obviously don't see that sequence between atrial filling to the QRS with that natural delay. So this is a medical emergency that requires defibrillation to occur. So these are examples of rate changes and interruptions or impulses occurring from other places other than the sequence between the sinoatrial node and the AV node. In blockages, when we have a block, let's just talk about these blocks for a moment. In AV blocks, what we have with an AV block is some sort of interruption or influence on the AV node. So there's some sort of interruption in the signaling between the AV node and ventricular contraction. So we have abnormal communication between the AV node and the QRS contraction, in other words, ventricular contraction. Now you can have a first degree block And in a first degree block, there's no effect on cardiac output, no significant effect at cardiac output. There is a delay between the atrium and the ventricles. So you'll often see a prolonged PR interval. So remember when we looked at a P wave and then a QRS complex and then a T wave, when we say there's a prolonged, so here was our, let's color code it, P, Q, R, S. So the interval between the P wave and the R is this interval. That's the PR interval. So in a first degree block, the only thing that might be noticeable is that this PR distance is prolonged. It's a little bit longer. There's a delay. So we have a delay between atrial and ventricular contractions. If cardiac output is not affected, which is the case most of the time with this first degree type block, there's no treatment necessary. But as soon as we move to a second degree block, the implications become a little more serious, although they're always in reference to the effects on cardiac output. In a second degree block, there are two types that we want to be aware of. In a second degree block, we have a type 1. And in type 1, there's ischemia at the AV node. That's what's creating the delay. So we're going to see a prolonged PR interval until a P wave doesn't conduct at all. So I'll show you what that looks like. So we'll write that down first. Prolonged PR interval. And sometimes that interval gets longer and longer and longer until we see a P wave doesn't conduct at all. Prolonged P wave intervals until P wave isn't conducted. So we miss a P wave. I'll show you what that looks like in just a second. So that's sometimes described as being a dropped QRS. And so then it seems to reset and repeat itself. So that's going to look a little bit like, is it in here? That's that one. So what's showing through there? That's showing through. So you can see here we've got a dropped QRS. So we got our PR interval is kind of shorter. It gets longer. It's longer again. And then we dropped a QRS. We missed the contraction. So the P wave did not conduct to the QRS at all. So we skipped a beat. And then we repeat. So this is a type 1 second degree block. It has implications and needs to be treated, especially if it's happening on a frequent basis. So let's go back here and look at our type 2. So second degree block type 2 is, in this case, we see a normal PR interval. So the distance between the two is normal, but occasionally we see non-conduction in the P waves. So we see irregular, non-conducted P waves. So what we're saying now is that there'll be more missed QRS complexes not that one, sorry. So here we are here. In this drawing, in this ECG, we see down here a normal cycle, and then we see a missed QRS, another missed QRS, normal. So again, this individual will be pumping blood, but the overall cardiac output is going to be severely affected. Instead of seeing a QRS every 4 squares, we can see that we're going between 1, 2, 3, 4, 5, 6, 7, 8. We're missing 2 complete beats in between. And again, 2 complete beats with irregular patterning, irregular non-conducted P waves. So when we say that term, non-conducted P wave, we have a P wave, but it does not conduct or transfer the electrical activity through the AV node in order to signal the QRS, the ventricular contraction. So these can come from lesions that are in either in the AV node or in the AV bundle or the bundle branches, anywhere that's supposed to continue the conduction to the Purkinje fibers so that the ventricles will contract. So our concern with type 2 is it represents a progression. And in blocks, what we're concerned about is we're going to go to a complete block. And if we go to a complete block, then that's described as a type 3 block. So we had second degree. So I will, for our purposes, squeeze it in over here. A third degree block is a situation where we're going to have a complete interruption in the conduction to the ventricles. So there's no coordination anymore between the atrium and the ventricle. And the result is going to be a decrease in ventricular contractions, which means we have a decrease in cardiac output. And that's going to look a lot like what's it looking a lot like? That's our 1, 2, and that was in 12. So where is our picture? So here we have, this is our picture of a third degree block. So in this situation, we can see that there is some ventricular contractions going on, but completely independent of the atrial contractions. So we're getting atrial contractions contracting at their rate and ventricular contractions happening at their own rate. And remember, if you put cardiac muscle cells in a petri dish with some oxygen and some ATP or some glucose so that they can make their ATP, they're going to contract at separate rates. So this becomes a completely uncoordinated, ineffective cardiac output cycle. And that's described as a complete block. So for ECGs, I think it's important to know for our purposes in this course, because we are not specialists in cardiac pathophysiology, the normal sequence, and to be able to recognize abnormal. So when we look at a normal sequence, we've got our P wave, our QRS complex, and our T wave. That's a picture perfect ECG. Anything out of the ordinary represents a potential challenge to cardiac output. So you should be able to identify the type of questions I might ask you are going to be very simple as far as the ECG goes. The ECGs that I've showed you in this presentation could be included in a question, but I would ask you questions in such a way as that you would be able to start to look at it and figure out what it is I'm talking about. So if we see atrial contractions in between ventricular ones, you're thinking about atrial flutter or fibrillation. If you start to see a really irregular, large waves happening with no obvious atrial contractions in between, it's probably ventricular, either ventricular fibrillation or ventricular tachycardia, because we lose our patterning in those situations. And the only other question I might ask you a little bit about is, for example, the difference between a type 1 and type 2 second degree block, because that was our QRS complexes are getting dropped either once in a while or with more frequency. In type 1, it was once in a while, and in type 2, it was with more frequency. And in type 1, what we saw was that PR interval was progressively getting longer till we missed a QRS complex, a dropped QRS. That's the terminology. Okay, not too many questions on ECG. It's complicated, it's very specialized, and we're just going to be talking about some of the introductory factors associated with that ECG.